Thank you. Good morning, all. I am so thrilled to be here, and I am shocked that so many of you from faraway places, very early places, are here. So, thank you so much for allowing me the opportunity to come speak with you. And I'm going to get control of the PowerPoint in a second here. Okay, we should be good to go. All right, thank you all. A couple just housekeeping items. I know Jenna already introduced this, but this is a 3-hour presentation. And if any of you or normal humans, your attention span will not last that long. So things that may be helpful, please get up and stretch when you need. I can't see it. And ask questions in the chat. So Jenna's going to be monitoring that, but please don't wait till the end of the presentation. If something comes up, please type it in there and let's address it as we go on. So funding, I do want to say, I want to thank VA CSR&D for funding one of the studies I'm going to be speaking about today. They have been wonderful, and they've actually funded multiple studies on aggression treatments. So thank you to them. I also want to give a shout out to my team members, anywhere from my co-investigators who helped me develop this manual, to my biostatisticians, to the people who actually run everything, who are the project managers and independent evaluators and data managers on the studies. So it takes a village to get research done, especially in the VA. We like to make things a little redundant. And so this team, if you ever have the opportunity to work with them, I highly recommend it. They're amazing, but don't come poach my people. Because I need them. So let's talk about the objectives for today. The first one is we want to talk about the rates of aggression in veterans, service members, and civilians. And then I really want to focus on how emotion regulation ability is related to impulsive aggression, which is a type of aggression, in those with PTSD. And then finally, we're going to talk about what to do with that aggressive behavior. We're going to demonstrate emotion regulation skills that have been used to manage different emotions and help decrease aggression. Okay, so going to start with this framework, affective neuroscience. Aggression can be really scary as a provider or as a human that it's being perpetrated against. And it's really an undesirable behavior in civilian environments, in most civilian environments. And so I want to introduce this framework that helped me become more empathetic and understanding of my own patients about how they could engage in aggressive behavior. And affective neuroscience is important because we're going to look at the central nervous system, or the neuroscience behind not just humans, but all mammals and even most vertebrates. And if we can understand these basic underlying systems that influence our behavior, that influence aggression, then we can start, one, predicting when those systems may go astray. And then two, understand the etiology, or the thing that is causing the aggressive behavior. And this really helped me take a different lens with my patients who were displaying aggressive behavior. Now, you may be wondering why this adorable pic of this pitty on the screen. Well, a few reasons. One, I used to have a brindle pit bull who looked similar to this. And then two, I want to continue to remind you that what we're going to be talking about today, this affective neuroscience, is not human specific. It is found across mammals. And so if all of these mammals evolved these systems, they must be serving a purpose. So I'll continuously remind you of that by these adorable animal pictures. Plus, you guys are from all over there, and I don't want you falling asleep. So I figure if I show you cute animal pictures, you may be more likely to stay awake. We'll see if that happens. So I'm going to start with a throwback to 2014. This is something I started working on in graduate school under the mentorship of Al Harkness and Scott Lilienfeld. And this is my favorite article that I've ever had the opportunity to help with. I'm going to hit the high points. But if you were interested in this topic, Al Harkness, the lead author here, did a TED talk back in the day. So it's a little bit blurry, but the content is good, about adaptive systems. And I encourage anyone who's even remotely related to watch it. So adaptive systems are at the core of medical knowledge and treatment. So when you go in to see a provider, they do this review of systems and they understand how our biological systems normally function. So you think of the visual system, the respiratory system, the cardiovascular system. So all of these systems are understood at you can do a higher up level of what their general purpose is to a cellular level. And you actually see medical providers in these subspecialties. If you have an eye problem, that would be a different provider than if you have a cardio problem. Unfortunately, psychiatry took this different path. And the way we classify psychopathology is through a descriptive list of checklists. Are you unable to sleep? Are you having intrusive memories? Are you irritable? And this is nothing about the underlying system that is contributing to the pathology. And the argument here is that if we can understand these major adaptive systems that underline all of psychopathology, then we can start predicting when they're going to go wrong and then knowing how to address those challenges because we understand what may be causing the challenges. This is very different than a checklist of symptoms that we currently use in our DSM. So 5 systems, major adaptive systems that are important for psychopathology. 1, reality modeling. So I'll go over these in a second. The second one is short-term danger detection. The third is long-term cost-benefit projection. The fourth, resource acquisition. And then finally, agenda protection. And as that acute pit from the previous picture or slide was supposed to show you, these systems are found across mammals. So it's not human specific. Reality modeling for action. This is how humans build mental maps and neural maps of the external environment. So in our head, if I say, think about going to a restaurant, walking in and what you do, most people will have a similar mental map of going in, seeing the hostess, being seated, looking at, can you show the slides in split screen? I'm not sure what that means. Mental maps of what to do in a situation. Sorry, my ADHD kicked in. I saw a comment. I'm going to let Jenna handle those. And most people don't come in and pick whatever table they want without asking or stand on the table or like my small children climb under the table because we have these mental maps of how shared reality is generally constructed. The problem becomes, and this involves the sensory system. So what you're hearing, seeing, tasting, it involves memory. If you've never been to a restaurant, like my 2 small wildlings, that can be a challenge. But then also cognition, what you know is expected of you. When this reality modeling system goes off the rails, you have things like psychosis, hallucinations, delusions. And so that is at the extreme end of the continuum, but we all have this reality modeling system. Hopefully we're all connected to shared reality. That's the first system. And that's important for aggression. I'll get back to that in a second. The second system is called danger detection. This is detection of threat of bodily injury. This system protects us, the fight, flight, freeze response. Most people are pretty familiar with this one. And pathology of this normally adaptive system that keeps you alive can be anxiety, it can be PTSD, it can be fear. The third system is the cost-benefit projection system. So this is one's ability to project into the future and think about future consequences. And if you think about the evolution of humans, for most of human history, we had 2 career opportunities. You could be a hunter or a gatherer. And hunters needed to be in the here and now. They needed to be able to take a risk with their bodies to be able to gain the food and bring it back to the tribe. They needed to not think about what might happen if they jumped off the cliff to try to get the animal. They needed to be able to be impulsive in a lot of ways to hunt. Gatherers, on the other hand, needed to prepare the seeds and to plant and to water and to be patient. And they needed to be able to project more into the future about how, even though you're not seeing the immediate consequence of this crop, we need it to survive the winter. So this cost benefit projection, when people are snarky about risk takers or about people who are externalizer, we needed these people. We need them in our culture currently, and we'll talk about how the military uses them. But they served an adaptive purpose, and we have them. Now, if you can't control your cost benefit projection, or if you don't have enough long-term projection, things like substance misuse, gambling, externalizing behaviors tend to creep up. And my mentor used to say, some people are just better at predicting what that tattoo is going to look like when you're 40 years old, working a desk job, and no longer that young kid in college who thought it was a great idea to get it. So we need these people. We need people who are hunters and gatherers. Okay, so we have the reality modeling system, we have the danger detection system, we have the cost benefit projection system, and then we have resource acquisition. And this is really like the happiness system. So humans need food, water, social exchanges. We need the tribe to protect us. And these, we need sex to promote the next generation. These resources produce happiness and joy. We need them. Lack of happiness, lack of joy in a human can be things like anhedonia and depression. Now, too much of this system often results in hypomania, which leads to bad decisions as well. And so this resource acquisition, this happiness system, is very important to promote the next generation. The final system is agenda protection. And think, when we're going to talk a lot about aggression today, this is the anger and aggression system. And so if you have goals, if you have an agenda, something you want to protect, and somebody is in the way of that or frustrating that, this will produce anger and sometimes aggression. Aggression is like an overreaction of this agenda protection system. So this is a lot, I know, and I promise I won't stick on this forever, but the stable properties of these 5 major adaptive systems are actually personality traits. And so if you can understand what a patient's personality, or really anyone's personality, you can start to predict their behavior and understand maybe some undesirable behaviors like aggression. One of the things to remember is that even when a system, an underlying adaptive system that we just reviewed, the 5, is contributing to psychopathology, it's probably still serving an adaptive function. So aggression has a purpose in our culture. And we need to be able to recognize the positive or the adaptive aspects of that in order to fully help our patients. And then finally, psychopathology can be a result of these underlying adaptive systems that worked in one environment that are no longer adaptive in the current environment. If you think about our service members, combat is a very different environment than being in garrison, in the home, going back to your family. And so switching those adaptive systems or editing those adaptive systems for each environment can be important. Okay, major adaptive systems, we need them, we love them. Now, this is the last affective neuroscience framework I will show you, I promise. But again, I think this is really important to kind of take an empathetic perspective for your patients. This is a depiction of your central nervous system, okay? Your nervous system is organized in a very predictable manner. At the lower ends, the caudal ends, you have the classic reflexes. And each layer of the nervous system has a very predictable organization. So you have a stimulus input, your integration within the central nervous system, and then you have a motor output. For the classic reflexes, think of the patellar reflex when a doctor hits that sweet spot on your knee, and then so that the stimulus input is the doctor hitting your knee. This integrates within the spinal cord, and then you have a very predictable kick out of your leg for the motor output. This same integration, input, integration, motor output, is found at all levels of your central nervous system. If you move a little north or rostral, you have the homeostatic level, which is things like blood pressure, temperature regulation. Think of the brainstem areas. And then a little higher than that, you have these basic emotion systems. Now, we talked about 5 adaptive systems. 3 of those 5 are really housed right here: danger detection, resource acquisition, and I'm blanking on the third one here because I'm in front of you guys. Seeking and joy, resource acquisition, fear, and anger and aggression, right here. And these are such important adaptive systems that let humans respond to their environments in appropriate ways. And if you move a little farther up, you have this working memory intensive cortex. So you think about cognition, visual spatial problem solving, and your memory. All of these levels interact. If you are hot, heat is a predictor of aggression. So if you are hot, you are more likely to be irritable and angry and aggressive. So this level influences this. So all of these levels interact with one another, but we're really going to be focusing on these 2, the basic emotion systems, and then what to do, how to regulate them. But mental health and psychopathology is related to all of them. The way people respond to the world are affected by individual differences. We need hunters, and gatherers. And we need people who are full of joy and happiness, but also who can control it. So we need individual differences as a culture. But let's look at these basic emotion systems, because while they're valuable and adaptive, they can also create problems. Right. Basic emotions, that level here. We're going to talk about 5 emotions that are found in every culture in the world, in most mammals, and even in vertebrates. So we have these for reasons. We're going to talk about anger, or the resource acquisition or protection. We're going to talk about fear, danger detection. We're talking about joy and happiness, sadness and disgust. Now, most people, when you say an emotion, people think of like this affective feeling, right? I feel angry, but that's only one part of the story. Emotions actually have 3 parts. You have the affective feeling down here. I feel angry. But then you also have the very predictable focus of attention and what it does to your cognition. And each one of these emotions does something different. You have an action tendency, or the hormones that are released in your body, the neurochemicals that are released in your body, and what your body wants to do. If you take anger, we'll just use that one. Anger actually draws you to whatever the obstacle is that's thwarting your agenda. You want to overcome it. Anger narrows your cognition to only focus on that obstacle. So that's why when people are so angry and aggressive, it's hard to think of the long-term consequences. It's only focused on the obstacle in your way. And then anger has a very predictable affective feeling. And some people like that feeling. Our service members and veterans report being very comfortable with anger. It is like a warm blanket to them on a cold night. They know what to do with anger. But yet sadness may be more uncomfortable for them, the affective part of it. Another thing to consider about emotions is that they each have a very predictable and recognizable facial expression. We'll go over this later. They have an action tendency of what your body wants to do. They focus your attention and your cognition. And they are signals of what is going on either internally or externally. I have a lot of patients who say, I wish I could just take the emotion out of my daily life. That if we could run on logic, we would be better off. And my argument to them is that while emotions are not always 100% accurate, you can have anxiety and there could be no danger. They're telling you what's going on. They're signals. They're something to just be mindful and pay attention to. So they're kind of like kids. Kids shouldn't be driving the car, but they also shouldn't be stuffed in the trunk. So emotions should not be making your decisions, but they should be something you need to be mindful and pay attention to. And one of the things that is evidence for this is that these systems would not have evolved and stayed within humans and all mammals. They wouldn't have been found across all cultures if they weren't serving a function. Oh, we have a good comment. Someone was once told that a patient that anger was the only authorized military emotion. The provider agreed, but pointed out that there's a lot of unauthorized things happening in the military. That's a great response. Um, yes, emotions is your body's way of telling you something is valuable and important to you. Love it. Absolutely. So, different ways of how we try to show our patients that emotions are adaptive, really important. Okay. And again, if you guys are asleep, here's a cute picture of animals to wake up for. Um, these emotion systems are not just found in humans. They're found in elephants who bathe one another and tickle one another with their trunks. They're found in fox and gorillas and mice and vertebrates. Um, and they're found in the young, they're found in the old, they're innate within us. And now you are taught how to regulate emotions. You're taught what emotions are appropriate and you're allowed to have. And that is culture specific. I was raised in Alabama. And while our military is so comfortable with anger, it's the only emotion that was issue authorized to them. Um, being a woman in the South, anger is a very undesirable emotion for a woman to have. And so culture really plays into that. Like if you are angry and a woman, are you allowed to express that? So even though the emotion is innate, there are ways to influence it and to regulate it. And that is culture specific. But as I was prepping for this talk, I have two young children. One is almost 3 and one is 6, and two little boys, two little wild tornadoes. And I was going over this talk with them, and I was just wondering if they could recognize facial expressions that are cross culture and found in animals. And so um, my almost 3-year-old, I asked him, I was like, hey, make a happy face, because happy faces are pretty easy to recognize, and they got it. Make a sad face. They could make a sad face. And they made all the facial expressions. They didn't understand the word disgust, but I said, make a yuck face, which is what my 3-year-old calls it, yuck. And he was able to do that. And the reason why he calls it yuck is that every night during dinner or the battle of trying to get my children to eat things, we say, don't yuck my yum. And so he doesn't know what disgust is, but he did know what yuck was in the yuck face. The only one he really struggled with was fear. And so that one he needed a little bit of work on. But a 3-year-old is able to identify and make the facial expressions. These are innate. So this is kind of a different way to conceptualize psychiatric distress. Emotions are adaptive. They evolve to promote survival. There are normal variations in set points. So how easy one is to experience an emotion. And this often is genetically influenced. Our personality traits are the stable properties of these emotion systems. And we know 50 to 60% of variance between two people in their personality is due to genetic variance. That's a lot. And the world and our lives and trauma can all influence those. But, we're kind of born how we are. And helping people accept these normal variations and how they are built and how easily they are triggered to have an emotion, how long they have an emotion. And really, as therapists, our ability to control emotions or manage them is, I think, one of the most helpful things a provider can do. So individual differences are needed and should be celebrated. Sometimes it's a little bit hard because in our culture, we value some things over others. For example, extroverted people have a lot of happiness and joy. That is kind of the core. Psychometrically, if you take apart extroversion, happiness is at the core of it. And so those people tend to be promoted more. They tend to be liked more. They tend to have better outcomes. So we as a culture really like extroversion and happiness. It's fun to be around, but yet we need introverts. We need people who have less of that happiness and that joy and who can plan for the future, who can think about negative outcomes and who can really be detail oriented. So we need all of this, but our culture punishes or rewards some types of personalities and these variations more than others. Now, the adaptive value of any emotion depends on the context and the environment. So I'm going to talk about combat versus civilians. So service members and veterans experience really unique challenges. The military uses emotions and emotion regulation techniques in such an adaptive way. Um, if the goal of the military is to fight wars, we need aggression. We need people who can use aggression, be it targeted and controlled. And so that is an adaptive behavior in many military contexts. However, that has to be regulated and the environment matters. So neither emotions nor aggression are actually the problem. It's when this environment changes or there's an inability to now regulate emotions. That's when the challenges arise. So, for example, the military uses aggression to get desired results. If someone is being aggressive towards you, that produces either a fear response or an anger response back, typically for people. And this picture of this gentleman yelling at the soldier, that soldier is learning to regulate his emotions in the face of aggression, which is needed. If you need to follow the rules of engagement while in combat, you need to be able to regulate your own emotional responses when someone is being aggressive towards you. However, that same behavior is less adaptive when we bring it home and we treat our children like we treat our soldiers. The aggressive behavior doesn't result in the same outcome, and it can lead to interpersonal violence. It can lead to challenges in the home. So really, the adaptive value depends on where you are and what you're doing. Okay. Since this is one of my transition slides, are there questions, comments, concerns that Jenna can field for us about what we've covered so far? Or is everyone asleep from the affective neuroscience slides?
That is not true. There is no sleeping through this talk. This is fabulous. I am not seeing any questions so far. If you were like, wait, I didn't get it in, feel free to put it in pretty fast. But I think right now everyone's tracking and we're just waiting for more cute animal pictures.
Okay, they're coming. They're coming. I'm just hang with me. All right. So the problem, again, not aggression, not anger. It's this chronic dysregulated anger and aggression. And I'm going to argue in a little bit later is that it's not just anger, it's emotions in general. We know that aggression is related to a host of negative outcomes, violence and relationship impairments, unsuccessful reintegration into civilian communities. So when a service member comes to transition into a veteran status, a veteran or a civilian position, anger is one of the top things that interferes with successful reintegration. It's also related to suicide. So if you have, we're talking about aggression towards oneself later, higher levels of anger and aggression are related to suicide. And even physiological problems such as cardiovascular disease. Now, I want to say something like I think the old way of thinking was like all anger is bad. If you're angry, you're going to have a heart attack. And that's actually inaccurate. It's really hostility or feeling angry toward people and thinking that they're angry toward you, trying to get them. That's related to cardiovascular disease. So you need anger and aggression, just being suspicious of people and trying to get them. That may not be the healthiest. And stroke as well, dysregulated anger and aggression. And then finally, from a PTSD perspective, so I'm a provider who does a lot of PTSD treatment. Chronic dysregulated anger and aggression are related to worse PTSD evidence-based psychotherapy outcomes. So it is worth teaching our patients what to do with anger and aggression, not only for their sake and all of these negative outcomes, but for your sake and hopefully with your stats of helping people recover from PTSD. Is it connected with fear at all? Yes. So I'm really hitting on anger and aggression, but later I'm going to talk about it's not really anger that's the specific emotion. It's this dysregulation of a variety of emotions. And I'll give you data to support that. Absolutely. I start with anger and aggression, one, because veterans and service members are so much more comfortable with it. And I think the field often thinks that it is anger that is the problem. And our data actually extend beyond anger. So anger management, right? It's the most common treatment that we give for people who have aggressive behavior. But I think we need to take a step back and not just be so focused on one emotion. Yeah. And Jenna had a good point. Providers might struggle more with anger versus fear. Yeah. Anger is scary. We're going to talk about what providers can do when a patient is angry and aggressive toward you. That's a really important thing as a provider to know how to manage. Okay. So this is a family event apparently, and I asked my husband to like look at my slides and that kind of stuff. And he was like, why these pictures of like this doesn't look like anger? And it goes to the fact that the military often uses anger to overcome all over other emotions. But anger can be triggered by the loss of a battle buddy. Anger can be triggered by these other more vulnerable emotions that someone is trying to suppress. So I know I'm preaching to the choir here, but I'm going to be very clear that anger is different than aggression. And this is important because our patients often equate the two. And as a provider, you have to help them distinguish between the two, because what happens is that they can often decrease their aggressive behavior and their anger still stays elevated, but that is still progress in treatment and it's still to be celebrated. So anger is an emotion. And the prevalence of anger really depends on what sample you select. So it says after combat deployments, about 50% of people have problematic anger. But if you look at large cohorts of studies, like the millennial cohort study has like 90,000 veterans, it found, I think, about 17% had problematic anger. We know certain psychiatric disorders are related to higher levels of anger, PTSD being one of them. A medical comorbidity, traumatic brain injury is also associated with higher rates of anger. So it's really sample specific, but it is one of the top concerns that veterans are reporting when they get home. Anger often precedes aggression, but it's not necessary nor sufficient. So just because you're angry does not mean you're engaging in aggressive behavior. When a patient says, oh, I'm so aggressive, I've now learned to say, well, what do you do when you are being aggressive? And you either get, well, I yell, scream, I throw things, blah, blah, blah. That is aggression. Those are behaviors. But oftentimes I get people who are like, I'm so aggressive. And I'm like, what do you do? And they say, I sit there and I don't say anything and I just stew. That's not aggression. That may be like passive aggression. You're not talking to the person, but you're not engaging in a behavior that would hurt another person. And so that's actually progress or better than them or those people who say, oh, I throw things, I yell, I kick, I scream. So that is a win if they can sit there and stew rather than lash out and engage in a behavior. Now, aggression is a behavioral act. It can be verbal. So telling people you're stupid, telling people you're worthless, yelling, shouting, but it can also be physical. And so psychological aggression is much more common. Physical aggression is less common. And there was this study of combat veterans, and 50% of veterans with PTSD reported engaging in aggression within 1 year of coming back from deployment. 20% of those with PTSD reported in severe violence that harmed another person. So you have a fifth of your combat veterans coming back and saying they harmed someone within the year of deployment. There's a question about anger being distinct from rage. I think rage is kind of an extreme level of anger. It's the same system within your central nervous system. Anger, anxiety, rage, they're all related, but it's a more extreme level. And we'll talk about intensity of emotions because that's really It's a really good point. So aggression is a behavioral act. Anger is an emotion. Help your patients distinguish between the two. Now, anger is not ideal, but this aggression, the behaviors, that's what really gets people into trouble. And it is related to occupational challenges. It's related to legal challenges. It's related to a host of negative outcomes. And so this is the area that we've chosen to focus on and try to help people reduce this. So why veterans and service members? They're actually at higher risk of anger and aggression than civilians. And I think there's a few reasons why that we'll go over. But we know that PTSD in both veterans and civilians is related to higher rates of anger and aggression. It's a symptom of PTSD, right? It was added into the DSM, I think in the DSM-4. And strong negative emotions is also a symptom of PTSD, but you notice the two are separated. So when you do a PTSD assessment, you need to separate it for the patient as well. Are you yelling, screaming, throwing things? That's aggressive behavior. Are you feeling very intense emotions, but not yelling, screaming? That's anger. So helping your patient distinguish between the two. Now, veterans have a more difficulty controlling their anger. So then it becomes aggression, right? If they're yelling, screaming. And this relationship is much stronger in veterans and service members than civilians. This 17% of challenges controlling their anger is that millennial cohort study of 90,000 veterans. So anger is higher in service members and veterans and civilians, but so is aggression. And one of the key things that predicts aggressive behavior is PTSD. Veterans and service members with PTSD have higher rates of aggression than veterans and service members without PTSD. Additionally, if you want to look at one type of aggression, intimate partner violence, so from male to female each year, it's about 12% in the US general population report intimate partner violence within 1 year. The range for veterans and service members is about 14 to 58%, depending on the sample. So it's a much larger issue for our service members and veterans for a variety of reasons that we're going to go over in a minute. And again, as providers, if you get nothing else, helping patients with anger and aggression is really important for you because it's related to poor psychiatric treatment outcomes. And when you ask veterans what their top treatment concerns are, what they want to work on, anger is one of the top concerns. So they are identifying it as a problem. Okay, so why? Why are service members and veterans so angry and aggressive? Well, there's a variety of exposures that they experience that are unique to the military that civilians don't generally experience that are predictably related to increased levels of anger. Combat exposures is a dose response relationship. The more combat deployments you have, the angrier you are. Post-traumatic stress disorder, higher levels of anger, traumatic brain injury. So we estimate about 17% of our service members will experience a traumatic brain injury during their service. And anger and aggression are common outcomes afterwards, and not just acutely afterward, not right after the brain injury. But we've done studies and we've looked for years afterward, and the levels of anger and aggression do not decrease just with time since TBI. PTSD, I'm going to circle back to that one. About 16% of our military cohorts meet PTSD criteria, and that's related to higher. Chronic pain, it has small to moderate correlations with anger. And our service members are more likely to have orthostatic or orthopedic issues, lower back pain, knee pain than civilians, age match control or demographically matched controls. And it's related to feeling irritability. It's related to irritability and aggression and anger. Alcohol misuse. Besides PTSD, this is one of the strongest predictors of anger and aggression. And unfortunately, our military culture really celebrates alcohol. I think there's been attempts to decrease this, but even with all of the funding, even with all of the resources pumped into the military, the rates of substance use disorders have not gone down. So alcohol misuse is alcohol is part of the culture, and it's related to higher rates of anger. And we really need novel interventions for this. If anyone is interested in a new area of research, my God, I hope somebody focuses on this. And then also impaired sleep. And about up to 48% of our service members report impaired sleep. That's really high. That's almost half. And impaired sleep can not only just be insomnia, which is very common in the general population and in military samples, but things like shift work messes up your rhythm and your sleep patterns. Things like obstructive sleep apnea, which you find higher rates of obstructive sleep apnea and those with TBI and those with PTSD. So there is a variety of ways your sleep can be impaired, and those are related to anger. We see similar predictors for aggression. A couple things that are slightly different. If you are a man, male sex is related to higher levels of aggression. What's in the general population, what's interesting about that is that in veteran samples, men and women tend to engage in equal levels of aggression. Again, something about the military context and what we're training people to do relates in equal rates of aggression for males and females within the military. Younger age is related to aggression. Listen, we all get old and tired, and we just don't have the energy to be so feisty anymore. And so, if you are younger, you're much more likely to engage in aggressive behavior. Alcohol misuse, dysregulation of emotions. So, this is not just anger. Dysregulation of all your emotions can lead to aggressive behavior. Traumatic brain injury, I already hit on that. PTSD, I hit on that as well. Okay. So a couple more details. Again, aggression is different than anger. The DSM separates aggression and anger for PTSD. So as a provider, ask the veteran what he or she does when he or she is aggressive. So don't just take their word that they're being aggressive. And I think someone brought this up earlier about different types of aggression. Aggression is motivated by different factors. And it's really important to understand what those factors are. Impulsive aggression is when somebody loses control. There's a stimulus, there's an integration within the central nervous system, and there's an output. These people often report regret for their behavior. They're like, wow, like I just lost my shit, lost my stuff, sorry. And I was okay 1 minute, and then I flew off the handle the next minute. And I'm not like, I know that that was too strong of a response. And they say, I want to decrease it. Like, I want to be a better dad. I want to be a better parent. I don't want to engage in this type of behavior. They come in seeking help. Now, they're still engaging aggression. They're still yelling, screaming, hitting people, right? But afterward, after they calm down, they want to change the behavior. You can contrast that with premeditated aggression. This is aggression that is not emotional, it's planned out, and it is controlled. Now, premeditated aggressors, you hear things from them like, I warned her, she should have known better. They get in my way, they're going to get the consequences. Listen, there's always going to be an alpha out there, and I'm just one of them, and everyone else is a sheep. So, like, even within the therapy room, you can feel it almost instantly when somebody's reporting aggression if they're premeditated or impulsive. And I will show you the scale where you can actually use, but it's usually very clear therapeutically. Now, if you had to guess which one of these types of aggression responds to anti-epileptics, mood stabilizers, would you guess impulsive aggression decreases with medications, or would you guess premeditated aggression? Put it in the chat. Premeditated, we get one for premeditated. That sounds a bit axis two. Yep. Impulsive. Okay. Yep. Okay, so we got a little bit of both. And the data show that if you are an impulsive aggressor, you're much more likely to respond to treatment because you are losing control. And we know how to teach emotion regulation. We know how to medicate and bring that mood down, right? So if you are impulsive and losing control and being very emotional, we have treatments for that. If you are premeditated, you are planning out when and how to behave aggressively, and it is working for you. And someone said, yes, it sounds a bit psychopathic or what we call antisocial. All of those terms overlap with premeditated aggression. It is premeditated aggressors think that they are above the person they are aggressing against, and they deserve it. So it's almost like this. It is a personality flavor of punishing someone for their misdeeds or using aggression to just get what you want, but it's not out of control. We actually don't know how to reduce premeditated aggression very well. Like there's treatment for antisocial PD, but a lot of it is helping like people find mutual benefits from not being aggressive, right? Like if you're aggressive, there are these negative outcomes. How do we improve your outcomes with not acting aggressively? And so we don't know what to do with them. But the thing is, for those with PTSD, especially veterans, if they're engaging in aggression, 70% of those veterans are impulsive aggressors. So people with PTSD are losing control. They have strong negative emotions. They're losing control. And it's impulsive aggression, which is actually good news because we can help them with that. Okay, Jenna says we had a question earlier. Would aggression occurring without anger be labeled as psychopathic or sociopathic? Yeah, so there's overlap in those constructs for sure. And I would say aggression that is, I wouldn't just say anger because fear can produce aggression. Sadness can sometimes produce aggression. So I would say aggression without the emotional response overlaps with the constructs of antisocial psychopaths, premeditated aggressors, using aggression in controlled manners, in a controlled manner to get what you want. So the most effective medication for impulsive aggression, Matt Stanford used to do a lot of work with this. And really the ones that are most effective are like mood stabilizers. Now, I'm not a real doctor, so my family is still disappointed that I got a PhD instead of an MD, but that's probably like 7 years old, that stat. So there may be new medications, but back in the day, it was mood stabilizers that were the most effective for impulsive aggressors. All right. Any other points about this? People seem to latch onto this one. You can feel the difference in premeditated versus impulsive aggressors for sure in a therapy room. All right. Okay. Now is the time for questions, comments, concerns. This is our transition slide, but I think we've answered most of them. A provider said, in my practice, I see a lot of this and hard when they're still active duty. You're right. Yeah, absolutely. It's very hard when they're still active duty because aggression, we need aggression in our military active duty, right? Especially our infantry. And so what do we do? And I think part of it is helping people use behavior that is appropriate to the environment. Harm reduction. Yeah. All right. So I want to cover like what to do when a patient becomes aggressive because it can be a very intense experience. I want to start with this discussion question. And I do this. Here's another cute animal picture. I know it's a lion, and that was like the closest I could get to animal aggression in PowerPoint. But I have treated aggression since I was a wee little lad last on internship. And I have botched how to handle aggression being targeted to me in every way possible. So I've been too passive and allowed patients to kind of like walk over me. I've been too aggressive in return and kind of got lippy with them. I have done every behavior in between because it's really hard as another human being when someone is being aggressive and to handle that effectively because your own emotion systems are going to be activated. And so, what have you done when patients have become aggressive? And either horror stories of where you botched it like I did or where you handled it like a champ. Put things in the chat that either went horrifically wrong or really, really well so the group can learn from your experiences of when a patient was aggressive toward you. Okay. Stayed multiple different ways. Stayed focused on the need. Perfect. Yes. Match their tone. Good. Told client to put down her hatchet. I hope that is a metaphor or an analogy. Change my tone of voice. Good. Remain calm and set boundaries. Put your hands up. I'm not comfortable with this behavior. Good. Um, got louder so another provider could hear. Yep. Calm but stern. Um, on a home visit, I had to leave the property. Yep. Yep. Reflection. Oh, good. Yeah. Can you provide an example of when that happened? My concern is that clinicians make it about them due to lack of emotional intelligence. Absolutely. Um, pulled them out of the group room. Yeah. Ducked a, ducked a bullet and crawled out of the room. I hope again that is a metaphor for something. Home visits, leave alcohol. Absolutely. Um, fogging technique. I want to know what that is. Um, Oh, made the mistake and said, just calm down. I love it. I love it. Because who hasn't made that mistake? And also what is so ineffective. I've done it. Yep. Said something outrageous to shock them. I love this. I'm going to keep these ideas and use them with future patients. This is really creative. Affirm emotions and use boundaries. I've quacked like a duck before. Oh my God, amazing. Okay, guys, this is so amazing. Really appreciate the feedback and the creativity. And I guess a couple, someone was like, can you give an example for me? I think my first example of like botching aggressive, like when like a patient is aggressive, I was in graduate school. And so I was like maybe 22. And I was working on an inpatient psychiatric stabilization unit. And we had a patient who was psychotic. And so she was coming down from her psychosis. They were trying to get her medications accurate. And back in the day, when I started, patients could smoke on inpatient units. And so this patient was known for getting up and leaving groups. She would just get bored, she would get up and leave. And my not very supportive supervisor at the time, again, this was my first clinical rotation ever, first time seeing real life patients in the wild on a locked in patient unit. My supervisor was like, hey, this patient's leaving group all the time. She's not supposed to do that. You tell her she leaves group, she will lose her smoke break. I was like, Roger that. I'm great at following directions. Let me lead the group. So I'm by myself, 22, been working with patients for about 6 minutes, and she gets up to leave the group. And I'm like, oh, ma'am, I'm sorry. If you leave the group, you won't be able to smoke later. And this lady who was coming off of her psychosis got about this close to me and called me lots of names and said, I will not determine if she smokes or not. And I froze like a bunny. I didn't know what to do, like big group setting, lots of patients, inpatient, had never had anything like that happen to me. And luckily, offer her a cigarette that would have diffused it. Instead, I told her she couldn't have it. So I was thwarting her goals, right? I was in the way. I was her obstacle of doing the thing that calmed her down, smoking a cigarette. And so her rage system went off, her anger system went off. Luckily, a couple other patients stepped in and they saved 22-year-old Shannon. Today, so and so, blah, blah, blah. And the patient ended up slamming the door and going out and smoking probably. So it was ineffective on a lot of levels, but I just froze. I didn't know what to do. Now, since then, I have done things like told people you will not speak to me that way and you can leave my office. Yeah, my supervisor, he was awful. Since then, I've botched it in other ways. I'm like, you can leave my office if you want to speak to me that way, which is also ineffective. Um, one example where I did not botch it completely, I used to do psych assessments for a PTSD clinic. And so anyone who couldn't figure out their, or providers who couldn't figure out their diagnosis would send them to me. I would do like a 4 hour psych assessment. Blah, blah, blah. And I had trainees with me, and I was about 9 months pregnant. I was huge. And this guy came in. I think he was stoned when he came in. I'm not really sure, but he had a substance use problem. And so I offered him a variety of resources about substance use. And this enraged him. Like this was at the end of 4 hours. Again, he was probably wearing off, his high was wearing off, and he was less friendly. And I gave him like a handout of resources. And he crumpled it up and he threw it like beside my head on the wall and then flings open the door and walks out. And 9 months pregnant, not moving too quickly. Okay. So I'm waddling out behind him, following him. It's a locked, our mental health clinics are locked because we were threatened a lot. And so he slams into the waiting room and he turns around and again gets in my face. And he's like, you shouldn't be working here. And then gave lots of descriptors about my appearance and personality. One of the least offensive was calling me prissy, which was probably accurate. And then the VA cops got involved. In that time, I didn't respond aggressively. I followed him out because we had to. That was clinic policy. But I didn't freeze like a bunny. I didn't become overly verbally responsive. And I was just able to maintain my calm. The VA cops did have to like escort him out, but it was such a different reaction from me. And it's probably because I had been yelled at that point. It had been a decade and I'd been yelled at a lot. But being able to maintain that sense of calm takes practice and you regulating your own emotions. So, all of that to say, if you mess it up, you're in great company. And if not, good for you. And there are wonderful suggestions in the chat of how to handle it in the future. Okay, let's talk about interpersonal skills. And again, the things in the chat are so wonderful that you guys should all read that. But your immediate reaction when a patient is aggressive is the most adaptive way is to remain calm. So it is so easy to get activated, and that's an adaptive response. But someone said, sit down. Don't have an imposing posture. Remain calm. You lower your voice. Humans naturally mirror one another. So if someone is yelling and you respond to them in a very calm, soothing voice, that discrepancy will often be enough to get them to alter their own behavior. You have to check your ego. Now, listen, I love the MDs, but when I train MDs, slow and low, that's right. When I train MDs, often their response is, well, I tell them who is boss. Now, I'm not saying all MDs. I've worked with amazing providers, but that generally doesn't work. That's ineffective when someone is emotionally dysregulated and impulsively aggressive. So checking your own ego. It's about helping the patient, not making sure that they think that you're right. And then setting boundaries. If alcohol or any substance is related, especially if you're doing things like home visits, the best course of action is probably just leaving because aggression with alcohol is one of the top predictors of impulsive aggression. People lose control. And your frontal lobes are shut down, so you're not problem solving. Now, health system considerations. This is really important for a couple of reasons. When a patient is aggressive toward you, you need to report the behavior in whatever manner that your system requires. And we do this because if you don't report the behavior and the patient goes to the next provider and does the exact same thing, you've kind of screwed over your provider friend because there needs to be a pattern, at least within the VA system, there has to be a pattern of behavior before things like flagging the patient's chart will happen. And what I've experienced in another clinic is that a veteran was engaging in aggressive behavior and was dysregulated. It was impulsive aggression, but no one was documenting it. And so when he actually assaulted a provider, they're like, oh, this is a first time offense, except that it wasn't. Just no one had been documenting the escalating verbal aggression. And so when it switched over to physical aggression, people were like, oh, this is abnormal for this patient, but it wasn't. There was a pattern of behavior. So in the notes, I would recommend direct quotes and behavioral examples. Don't just say patient was aggressive. Say what they did in behaviorally anchored terms. So patient yelled at this provider that he did not want the resources that she was handing him on the flyer. Um, Sometimes if it's a really funny descriptor of me, I put in a direct quote of how they view me. And I make sure I quote it so I don't get flagged for cuss words in my notes. But it really demonstrates the dysregulation. There can also be formal reports. The VA has kind of like you can note it in their chart. And then there's also a disruptive behavior secondary system. So the provider just the patient can't see if the provider reported them. So that's to protect providers. We have panic buttons in the VA, which are pretty effective. They test them all the time. And turns out if you're not paying attention and you click it twice, as I did, the VA cops will run to your door. But having some type of way to alert either the people around you or the police for really aggressive patients that need treatment that are having trouble like maintaining boundaries, we've notified our police in our clinic or VA cops, and they have kind of like done circles just to make sure, like if I start screaming, they come in. So like letting people know you still want to have a confidential session, but you want to have resources in case things get out of hand. And then having another provider in session with you or in group with you can be really important. Any other healthcare system considerations for your specific place that might be helpful for the group? Or any ways that you guys do it better? How to evacuate? Yeah. I love every safety training I've ever attended. It's like, don't have anything between you and the door. You should be able to evacuate while working with mental health patients. In every VA office I've ever worked in, the door is over there. The patient sits between me and the door. And so I would have to go through them. And so, yes, setting up the physical space to increase safety is an option. I don't know how many places that's feasible. Another recommendation is reminding the person that if they feel dysregulated, unable to control, they can leave and take a cool down. Absolutely. Words or phrases to alert others. Yes. Yeah, absolutely. Good. Okay. So let's talk about assessing anger and aggression as providers. I want to start with some ethical considerations. Treating anger and aggression, especially aggression, is so important and it's so needed within our veterans and service members. So if you're doing it, I really appreciate that you're doing it. But there are some ethical considerations that get stickier with aggression. We, as mental health providers, are mandated reporters of child abuse, elder abuse, and vulnerable populations. By ethics and law, we have to report them to appropriate state agencies. Additionally, mental health providers are obligated to protect persons who could be harmed, so the terrorists off. Now, specific laws about this vary by state, like what crosses the boundaries of you having to inform either the person or law enforcement. So check your state laws. But one of the things that you need to do as a provider is that you need to let your patients know what your reporting requirements are at the onset of therapy. There should be no, and we should do this anyway as providers, right? And especially within the military, because I was recently informed that in the military, you have to, as providers, have to report more things than a civilian provider does. So correct me if I'm wrong, you DoD providers, but in the DoD, if there's domestic violence reported in session, I believe you have to report that, which is not a civilian thing. That was really surprising for me to learn. So you guys have an extra. What is FAP? What is that? You guys have an extra reporting requirement. Family advocacy program. Okay. Yeah. And so it gets really complicated really quick, especially with active duty samples. So you need to let your patients know this. In terms of aggression research, we have what we call a certificate of confidentiality, what we call, NIH calls it, like I made up the term. We have a certificate of confidentiality for the study, which says even besides these three circumstances, children, elder, or vulnerable populations, we will not report any other aggressive behavior. And we don't even put notes in their charts that say aggression. We just say this person showed up for a research study. Here's the number, but we do not say anything about aggression because it is such an undesirable behavior that has legal consequences that a lot of people don't seek treatment. But this we do have to report. And making sure they're aware of this. And people often don't realize, I'm like, a child is anyone under the age of 18. So if you and your 17-year-old son get into it, legally, I have to report it. Jay says, no, we're not mandated reporters for domestic violence. The idea is that to similar cases of sexual assault, the patient has the right to decide with support whether or not they want to file a report. Well, what if your patient reports perpetration of the domestic violence? Do you as a provider have to report that? Oh, okay. So there's some discussion about this. Okay. Okay. So the DoD is complicated, to summarize that. But what, as a provider, you have to have this conversation up front, or you're going to lose all rapport with this person who's coming to you and asking for help. Okay. All right. So if you want to measure these things, here are common anger measures and then decided aggression measures. Now, I think the most common one is the state trait anger expression inventory 2. And this is like different facets of anger. So like state is in the last, I don't know, maybe I think it's a month, how often you were angry. And trait is this personality of stable properties. Like in general, what is your level of anger? It's kind of long. So clinically, I give out the dimensions of anger reaction scale. The DAR is five items, pretty quick and dirty, but it will give you an example of how angry they are. For aggression, again, those are emotions. Aggression, if you want to subtype into impulsive versus premeditated, there is the impulsive premeditated aggression scale by Stanford. Now, it's like a 30 item scale, but only 17 of those items, 15, 17, go into the actual subscoring of the two types of aggression. We give this measure or those 17 items in our studies because we know premeditated aggressors are not going to respond to our treatment. So we exclude them from our study. If you want to look for frequency of aggression, we use the overt aggression scale. And it's been around forever. We've modified it. So we added things like aggressive driving. And then also with our most recent clinical trial, we found that people were engaging in a lot of like virtual aggression. So texting, like mean things or violent things, or other things on the internet. So we actually had to add items for that because it came up for the first time in this latest RCT. And then also there's this revised conflict tactic scale, and it has physical and psychological aggression in the past month. The original one was against a romantic partner, but we've adapted it in some studies to just do any psychological and physical aggression in the past month, which is more helpful if it's not necessarily IPV or domestic violence, and it's just general aggression against lots of people. All of these, I believe, or most of them are in the public domain. So you can get your hands on them. This is an example of the overt aggression scale. It's just literally write the number of times in the past week that you've done verbal aggression, physical aggression against others. I'm sorry, against objects. So slam the door, scattered clothing, minimus, through objects. Throwing dishes is pretty common. Broke objects, smash windows, set physical aggression against self. We get less of this within our veteran samples, and we treat combat veterans, but I would imagine, especially within adolescent samples, that this might be higher, these physical aggression against self, and then physical aggression against other people. And so made threatening gestures, swung at people, grabbed, hit, push, shoved. And so someone had a really good example of when measuring aggression that seems subjective, will it always be up to the patient what is considered aggression? No, because oftentimes patients don't know that they're being aggressive. Impulsive aggressors are actually really poor historians for their behavior. So part of the treatment is we have them start tracking their aggression, and they come in and they're like, oh my God, apparently I'm yelling all day. And we're like, yes, that's why your wife really wanted you to come in. But they are often unaware of it. So we give very behaviorally anchored, made loud noises, shouted angrily. Like, it doesn't matter what you said. Did you do this? And if you did, how many times? Yelled mild personal insults. You're stupid. F you. You're an idiot. All of those things go here. Cursed. So we give them very explicit behaviors because oftentimes they are unaware that they are behaving aggressively all day. We added this drove aggressively, and we also added those virtual items I talked about, like text, people, and also passive aggression. So a lot of people discuss how they remove any communication from people to punish them. So it's not a yelling, kicking, those types of things, but they are trying to punish. Now, that doesn't go into our total score, but we are tracking how much people withdraw love, withdraw attention, withdraw talking as a form of aggression. It's not typical, right? Like, it's not the classic aggression, but people are reporting it at high rates within our current sample. Okay, so this is an example of OAS, overt aggression scale. The reason why you want to use a scale, whichever one you choose, is that it is very hard for a patient who has a lot of emotions to notice their decreases in aggression without some type of metric. And so when they come in for their baseline assessments for us, we say, please track your aggression every day using this sheet. You can just tally it up for the past week. And they come in and there's a predictable increase in aggressive behavior. Every time from when you start monitoring it to session 1, there's a predictable increase because they were unaware of it. And so if you don't have them track it, they don't know what their level is. They're usually unaware of how frequently they're engaging in the behavior. And then you get to celebrate with them at the end of the treatment when they do make progress. And numbers are really impactful for people to see that they're making a decrease. So I know you guys are probably horrifically busy providers, but making sure you track symptoms no matter what it is can be so helpful for the patient. Ooh, I really like this. Someone put a quote that Annie Sarwald, a cultural anthropologist, has a few books on facial expressions that are helpful to those wanting to sharpen reading on emotions without word exchange. Excellent. Love that. So important. We're actually going to get into facial expressions. And so Jay also put 2 DoD resources that are open source about reporting requirements. So great. Thank you for clarifying that. Let's talk about now what we do. We can identify what the problem is, aggression in inappropriate context or emotions that are unregulated, but like, what do we do with them? And so let's review what we've traditionally done with them. Mainly what we do is anger management. We have tried evidence-based psychotherapies for PTSD, newer multi-component treatments. So this was like PTSD and anger treatments, and then mind body approaches. Now, I'm really going to focus on what do we do for anger and aggression in PTSD populations, because that's my area. But some of these are not specific to PTSD. So anger management, cognitive behavioral therapy, usually about 12 sessions. It's moderately effective at reducing anger. So you see moderate to large effect sizes. It's unclear if it reduces aggression because oftentimes people don't measure it. And so anyone who is doing aggression and anger research, I really, really encourage you to try to measure both constructs and not think that they're the same thing or not act like they're the same thing, because much of the literature just adds anger and aggression as one construct, which is inaccurate. So if you give somebody anger management, it's moderately effective at reducing anger. It's pretty good. I was lucky enough to do some secondary analysis with the Strong Star group out in San Antonio and Patty Rezick on her randomized clinical trials looking at cognitive processing therapy for PTSD in active duty service members. And what we found is that anger and aggression do show small to moderate reductions after cognitive processing therapy. But most service members continue to report clinical levels of anger, and aggression was still present. Even the people who had optimal treatment responses continue to have anger and aggression after CPT. This is important because the correlations between anger and aggression and the changes of anger and aggression pre to post treatment only had small to moderate correlations with the changes in PTSD symptoms. So it's not necessarily the PTSD symptoms that are contributing, or I would say the etiology or the cause of the anger and aggression. Then we looked at, analyzed data from multiple clinical trials, and we looked at hyperarousal symptoms. Because if you look at people with PTSD, clusters B, C, and D are very specific to the trauma. So re-experiencing avoidance and these changes in thoughts and emotions. But the hyperarousal symptoms are really transdiagnostic: insomnia, anger and irritability, hypervigilance, risk-taking. And so we found even after successful PTSD treatment, hyperarousal symptoms linger at a much higher rate than any of the other, excuse me, any of the other symptom clusters. Excuse me. Okay. So multi-component treatment. So this is like a PTSD plus an anger management. They're moderately effective for anger. We're unclear about aggression. And then finally, mind-body approaches. They're actually ineffective for anger in the context of PTSD. So at best, we are moderately effective at reducing anger. It's unclear how aggression does, except for evidence-based psychotherapies. It's moderately effective. This really suggests that we have room for innovation in helping our patients reduce anger and aggression. And I want to bring us back to all of the different military exposures and experiences that are related to anger and aggression. And there are many, right? And I like this quote: "We're surrounded," that simplifies the problem. Now we can shoot at them from every direction. And as providers, if you can help with any of these, you are likely to help decrease the aggressive behavior. So often in mental health, our lane is maybe emotion dysregulation, helping them with that. But you can refer them for a sleep study if they're reporting sleep problems. You can assess for the chronic pain and see if there's a PT available. You can look for those who are having challenges with alcohol. There's just so much room. You can go in any direction and help people with these exposures. But I'm going to focus on emotion dysregulation and impulsive aggression. And this is because I'm a psychologist and it's kind of my wheelhouse, but it's also because this is one of the things that we found has been most helpful out of those military exposures, and something that is a target that can be addressed. So our early work on my internship and postdoc, we looked at the relationship between PTSD symptoms and impulsive aggression. Now, the literature had documented this relationship forever. That was not surprising. But what we found is that if you added in The emotion dysregulation, or the inability to name, to label, to recognize, to regulate your emotions. This completely mediated the relationship between PTSD and impulsive aggression. That is thrilling for a provider because we know how to teach emotion regulation skills. That is something psychologists, mental health providers, whatever ones, we all know how to do. And the fact that it was a full mediation within combat veterans who had PTSD, that was really striking to us. And we also replicated it in a sample of college kids. And what was interesting with the college kids, and these were actually different scales, so not even the same scales, but we found trauma exposure was related to emotion dysregulation, which mediated the relationship. Sorry, trauma exposure, impulsive aggression. Emotion dysregulation mediated this relationship. But for college students, this emotion dysregulation also mediated the relationship between trauma exposure and premeditated aggression, which we did not find for combat veterans. So there may be something different about college students and their dysregulation and their levels of aggression. They're younger on average than our veterans that we were seeing. Less frontal lobe development. So there might be a variety of reasons. But we did find the same relationship that emotion dysregulation was partially mediating the relationship between trauma exposure and impulsive aggression. So this is really exciting. We know how to teach emotion regulation skills. So the idea was, let's teach them. Let's see if we teach veterans with PTSD and impulsive aggression the adaptive values of emotions, how to identify them, how to regulate them. Can we reduce this behavior that's getting them in a lot of trouble? However, we all know veterans with PTSD have high dropout rates from evidence-based psychotherapies and therapies in general. And so even with highly effective treatments such as cognitive processing therapy, prolonged exposure, EMDR, about 50% of patients who start drop out. 50%. So as a provider, we knew that most people who drop out do so usually by session 3. So we decided that if we were going to make this brief treatment, let's make it brief, let's make it specific to emotion regulation, and let's make it for the amount of time they're often giving us that they're going to drop out, which is 3 sessions. So we developed these manuals and conducted a case study with 10 veterans. And then we did a larger pilot study with 20 veterans. And now we're in the middle of doing a randomized clinical trial within the VA. And we're about to start a DoD trial with active duty service members. So this treatment is called Manage Emotions to Reduce Aggression. So I am a data nerd, and I've realized that one of my strengths is not being creative. And so this manual was developed before I hired public health staff who were excellent at disseminating health-related information like this. So bear with me with my non-creative title, and you see the beautiful graphics here. And you have these treatment manuals or the most up-to-date treatment manuals in however Jenna and the team shared the materials. So this was, we did a couple studies with MERA, this non-beautiful manual, but effective. And in our intent to treat samples, we found moderate reductions in frequency of aggression and emotion dysregulation within 3 sessions, which was really exciting because we at least saw a signal within the small sample that showed that people who used emotion regulation skills reduce their aggressive behavior and their dysregulation. Very exciting. So now we're on to a clinical trial, a randomized clinical trial, because I'm very excited about this treatment and I don't want the outcome results in our studies to just be due to my excitement, because once I'm gone, that will fade and then our patients will still have aggressive behavior and it wouldn't have helped. So we are now halfway through a randomized clinical trial of post 9/11 combat veterans. And they all have at least subthreshold PTSD and impulsive aggression. One of the things I want to point out is that full and subthreshold PTSD have about equivalent rates of aggression. So if your patient is not meeting full criteria, it doesn't really matter. One, they respond to evidence-based psychotherapies for PTSD pretty well. And then two, they also have equal rates of aggression. So we make these lines in the sands. Going back to the review of systems and the adaptive systems, we make these lines in the sands of like, this is the diagnostic criteria. But in reality, nature doesn't follow our lines in the sand, and these people will still need treatment if they're subthreshold. So we're doing a full randomized blinded clinical trial. We're comparing MERA to 3 sessions of present-centered therapy. Now, back in the day, present-centered therapy was developed as a control group for the studies that were testing prolonged exposure and cognitive processing therapy. But we now know that present-centered therapy is pretty effective at helping people reduce their PTSD symptoms. And so even Patty Rezick at one of the Strong Start conferences said, yes, present-centered therapy is effective. The clinical practice guidelines recommend it as a second-line treatment. So people who are unable to tolerate or unwilling to tolerate the 3 evidence-based psychotherapies for PTSD, this is a good option. We chose it because aggression is so damaging that we needed an active control group. We couldn't say we were giving someone no treatment with aggressive behavior, and our IRB approved that. However, that has created more challenges for us because present-centered therapy is pretty effective. And I'll show you the results, our interim results in a minute. Our primary outcome measure is the modified overt aggression scale, which I showed earlier. And then our secondary outcome is the difficulties in emotion regulation scale, the DERS. And we're going to be looking at changes in OAS from session 1 to the post-treatment assessment. Now, this is the kind of the flow of the study. We have the consent, we have the baseline assessment. This is when they start tracking their aggression. And when I talked about a predictable increase, there is an increase from baseline assessment to session 1 in aggression in all of our patients. So when people start tracking, they report more aggression. So our outcome will look at changes from session 1 to the 2-month post assessment in this clinical trial. And here is our clinical trial stack glove ID if you want to look us up. We did an interim analysis for 65 combat vets last year. Now, we don't know which treatment group is MERA or which one is present-centered therapy because the study is still blinded. But we found at session 1, our patients reported an average of 34 aggressive acts per week, yelling, screaming, hitting. After 3 sessions and at the post, they reported 15. So it's a large reduction across both groups in aggression frequency. However, with 65 combat veterans, and so our final sample will have 204, so this is slightly less, there were no differences between these 2 groups. No, let me be clear. There were no statistical differences. The adjusted mean difference was 5 points, but we don't know, again, what line is what group. So we're hoping, well, to be perfectly honest, I'm hoping MERA works because I've put a lot of time into it, and then I'm hopeful that teaching emotion regulation skills is effective. If it doesn't work, then we know that both present-centered therapy and MERA are resulting in large reductions of aggressive behavior per week. And maybe both are effective. Now, we have about a year left of that study. So then hopefully maybe we come back and we find that the results turned out. And if not, science is science. So let me walk you through the content of MERA. Because you have these manuals, I hope that you go and make them your own and you use them. They are in the public domain because your tax dollars helped me develop them. I hope that they're useful within your practice. So session 1, introduction to emotions. What are emotions? Kind of the thing that we did earlier. Education about three basic emotions. We start with anger because it just feels so good for our service members and veterans. And then we do sadness and joy. And then we do skills training. And this is really the structure for all of the sessions. Um, we provide a treatment rationale, discussions of veterans' current emotion regulation difficulties. Now, they will not label it as emotion regulation difficulties. We give them behaviors and say people with PTSD often have these challenges. Which one of these are you experiencing? Things such as, I don't know what I'm feeling, or I feel very intense and don't know what to do with it, or I shut down all of my emotions. So, all of those are very common in PTSD and signs that people are not regulating their emotions. And then we will go through education for these three, and we talk about the triggers, what happens with their thoughts, and what their body does. And we're going to walk through examples here. And then we teach them progressive muscle relaxation and grounding. I have never said that this treatment is unique or special, because you know what? These skills are not new. We've been using these skills forever. It's really the packaging that we were testing because we wanted to see if we could condense it, if we could boil it down to what was important to help reduce this one behavior. Session 2 is very similar. We talk about how your childhood military influenced your emotion regulation strategies. This is important because there's so much shame with impulsive aggression that if you talk about, well, you're regulating these emotions because in past environments, this was helpful. It kind of normalizes how this person became who they are and how they develop these behaviors. We talk about disgust and fear. And then we do 3 more emotion regulation skills. Again, these are not new skills. We all know how to do these. And they're effective at reducing aggressive behavior. Session 3, we talk about PTSD treatments because what we find is that people can reduce their aggressive behavior. And we are finding about a 7-point reduction on the PCL, which we were not expecting, to be perfectly honest. But it might be the PCT helping us out. We'll see when we unblind the study. But they're going to still need PTSD treatment. Even if they're regulating their emotions, it's unlikely to get to that trauma and help them process that. And so we talk about what emotional experiences they can expect during PTSD treatment. I did a study a few years ago that asked people why they dropped out of PTSD treatment. And they said, the top reason was I was worried I wouldn't be able to handle my emotions during treatment. So this fear of one's own emotional experience was the top reason people dropped out. So we hit this in the manual. We talk about like you are going to feel intense emotions and you are going to be able to regulate them with these skills that you've been learning. And we practice mindfulness. We call it riding the wave. But that is something that will, emotion is something that will come over you and it will also fade. So basically setting them up for the top reason people drop out of treatment or the top reason they report it to us anyway. So let me show you what that looks like. Remember, 5 basic emotions. And yes, Deborah, this was originally designed to give to patients while they were waiting for PTSD treatment. We haven't tested like the order effects, but that was when we were getting our patients. At least back in the day, we had a wait list for our PTSD clinics. No more. We've addressed that, but we gave this to patients who are waiting to start an EBP. Can you break down the sessions further for primary care behavioral health? Yes, I'm going to show you what's in the sessions right now. We're going to play emotion regulation games right now. So we talk about the 5 basic emotions. And I'm going to start with anger again, because people are comfortable with anger. And we talked about how anger is part of the agenda protection. If you have goals, if you have an agenda to protect, anger is going to help you do that. You need anger. And it does this very predictable thing. It narrows your thinking to focus on the obstacle. And it moves you toward whatever that obstacle is. So you guys, as providers, I want you to think about what your own anger triggers are. Because if you can do these skills within yourself, you're much more likely to be able to teach them to your patients. And also, even just thinking about your triggers may develop or trigger that physiological anger response. And so you can kind of see what your body does. And so for me, traffic, I'm pretty horrible in traffic. Inefficiencies, redundancies. So if I have to fill out the same form, and I work in the federal government, so that's like half of my job is filling out the same form repeatedly. So all of those things kind of get me. I have a 6-year-old who exposure works, Shannon. I've been exposed for 15 years. Exposed to inefficiencies. And I have a young 6-year-old who's really good at pushing buttons. He loves to say things that he's not allowed to say. Like, he was talking about if he could be any animal, he would be a gorilla. So he could pull people's arms off. And he's gotten in trouble at school for saying that. And I'm like, buddy, you cannot say that. And he knows he gets a response from me when he says stuff like that. And so it makes me angry. I'm like, you are literally playing me. And I'm also angry at myself for allowing a 6-year-old to play me. So those are some of my triggers. Think about your triggers and say them out loud. Good. Redundancies and efficiency, stonewalling, double standards, repetition of sounds, or dollars why. Integrity violations, absolutely. No in situations, traffic. Great. And what is your body doing? Traffic and efficiencies when worked in the DoD, people asking why. Cruelty, waiting, hypocrisy, good, injustice, absolutely. I literally vibrate. Someone says their body vibrates. Absolutely. So much worse. Your anger is so much worse when you're tired. 100%. People who turn off their blinkers. Yeah. A predictable. I love your anger triggers, and I'm laughing because they're common and I'm identifying with them. So predictable physical signs that you are becoming angry. Your heart rate increases. Muscles get tense so you can react to the obstacle. And then blood flow increases. So if you need to engage in aggressive behavior, your blood flow, your heart starts pumping faster, so it can fuel your muscles with oxygen. I get very hot. I can just feel like the anger. Like, I kind of joke that it comes up from my heart and like it just comes over like my neck and my face. And so the point of recognizing your physical signs is that often patients, this will be the first thing that they identify. Many of our patients with PTSD have alexithymia and they're unable to identify their emotions, but they can feel their bodies. So if you can train them to notice what's going on in their bodies and associate that with the appropriate emotion, they can start pairing it. They can start identifying what is going on. So this is really important because our service members, on average, men raised in the United States are not taught a firm foundation in emotional awareness and identification. They're often a little bit phobic of emotions. I was even told not to label this treatment manage emotions because it would turn people off. So, having them recognize their body is something they're usually able to do better than recognizing the affective response. Another provider tells them when muscles relax, things are less painful in the body, 100%. And progressive muscle relaxation is really good about that, because oftentimes they are not aware of how much tension they're carrying around. Now, I'm going to pause this. So people recommended I do video clips. And so if you want to increase your feelings of insecurity and anxiety, just videotape yourself and then play it for 74 people. And that's what I'm going to do. And this is one of my lovely project managers here at Michelle. And we're just going to, what is your SUDS, Genesis? Oh, on a 1 to 10, about a 5. She is my project manager, and I'm just going to go through the anger worksheet with her. This is in your manual, but it's also painfully awkward for me to watch myself on video. So here we go. All right, Michelle. So the first emotion that I want to review is anger. And anger is a really helpful emotion that's really adaptive, and it is a sign that something is keeping you from meeting your goals. So if there is an obstacle in your way, something that is preventing you from getting what you want or you need, anger is a normal reaction to that. And one of the things I want us to do throughout this treatment is to talk about when you're having an emotion, to label it. So to be able to identify it, notice that you're having it in your body, in your mind, label it, and then that will allow you to decide if you need to regulate it or not. So anger, really powerful. It helps you overcome obstacles. It helps you meet your goals. You need it. Without it, you would be a doormat, which is also not the desired response. It does three very predictable things for your thinking, for your body, and then I want to talk about what your individual triggers are. Okay. So the first thing, when you become angry, do you notice anything specific in your thoughts?
I get focused on only that thing that's making me angry.
Absolutely.
Yeah.
So if you're really angry, you may think about it a lot, you may run it over in your mind a lot, and you kind of just go over it over again and again and again. Yeah. Or if there's a physical object, that person becomes the sole focus of your attention.
Yeah.
Okay, perfect. So it narrows your thinking. When you become super angry, do you notice your body does anything?
It tenses up.
Yes.
Yeah.
Okay, absolutely. It tenses up. And when we talk about the normal action tendency of what an emotion does, usually when you're angry, you want to go toward the obstacle.
Oh, okay.
So in our culture, that's trained a little differently for men and women. Women are often taught to suppress their anger, but in general, without that filtering of culture, most people want to move toward the obstacle to overcome it. And so this could be things like if you're cut off in traffic and you become angry at the driver, you could have a thought like, screw them, honk your horn, how dare they keep me from getting to work safely or disrespect me, whatever that thought is that accompanies the anger. Okay, so it narrows your thinking and makes you move toward the object. What are your triggers? What makes you angry?
You mentioned traffic. That's a trigger. So any driving, when people are driving recklessly or there's traffic.
Okay.
And then I think my kids when they're moving slowly.
And what your children, yep, identify with that. What are they keeping you from doing?
Getting to the next place or the next task that we need to complete.
Absolutely. Okay. And I want you to look at your sheet. At the bottom there, there's a little picture of a human figure, a silhouette there. What does your body do when you become angry?
Like I said, I think it tenses up. Like my shoulders feel tense. You feel like your heart rate increasing. Do you want me to mark it?
Yeah, go ahead and mark it on the body.
So like shoulders.
Yes. Or just, and you can also put arrows on the physical signs that you're becoming angry.
Okay.
And the purpose behind this is that often you will feel a physical response before you're even aware of the emotion.
Okay.
So if you can become aware of what your body is doing earlier, you can start the emotion regulation still earlier if you need to do it. Okay. And so a lot of people talk about how they feel hot when they're angry, like they can feel the blood come up through their body. Blood pumps to the large muscles so you can prepare to fight said obstacle. Hopefully we're not doing that, but if that's the case, your vision, you really focus in. It's hard to take in any other extra information, which is why sometimes people are not as logical when they are angry. And then the final thing, do you know what you look like when you're angry?
I think my face gets red and I'm breathing heavy.
Yes, yes. And there's a very predictable facial expression for the 5 basic emotions. And if you can identify them within yourself and also within other people, it helps you regulate your own emotions. Okay. Because we know people with PTSD tend to overrate facial expressions as angry and dangerous. Okay. And so we need to have an accurate estimation of what other people are feeling so you can judge your emotional response. Does that track?
Yeah.
Okay. So this picture here of this gentleman, how can you tell he's angry?
The furrowed brows.
Yes.
And the eyes are squinty.
And
the lips.
Now.
Yeah.
Absolutely. And so if you see that, you can identify anger, but also within yourself. Most people don't even know that they're making an angry expression. And changing your expression can actually start a different emotional response. So it's literally smiling in the mirror, like they do that in the movies, like, and it's really hokey and corny, but it works. If you smile, it actually starts changing your own emotional response. Okay. Any questions about anger?
No.
Okay. All right. Is that Chris Pratt's face? It's not Chris Pratt, Aaron, the picture on it. It's actually my husband. And he loves that he gets to participate in every talk I do about anger and aggression. Okay. So that was just an example of educating a patient about the adaptive value of anger and going through the treatment manual. There are no right ways to do it. Make it your own. Just being able to give your patients some accurate information about the adaptive value of whatever emotion, and then helping them identify it in their thoughts, what triggers it, and in their body. The next emotion is fear. This is not as accepted as anger. And so that's why I don't introduce this one first. And actually, I've had, I'm here at the Tampa VA, so we're co-located with SOCOM, Special Operations Command. And so many of all of my current patients are either active duty or recently retired Special Operations Forces. And I've literally had people laugh at me when I introduced the concept of fear in session. They laughed at me. And then to their credit, I had one gentleman come back and say, well, after a session, I had a panic attack in the parking garage. So maybe I am experiencing some fear. But this is not an accepted emotion within our military community, but it's so needed. It's a sign that your mind and body think that there is active danger somewhere. It narrows your thinking to focus on the threat and how to escape. And while this is so adaptive, if you are running away from a lion or in combat, this narrowing of your cognition inhibits you to be creative at work, to connect with other people, or to be able to problem solve when you are in a jam. So fear is so needed. But if it is running your life, again, if it is driving the car, there are a lot of predictable negative outcomes. And so it actually moves you away from the threat. And you have this very predictable fight, flight, or freeze response. Now, this also brings chuckles from special operators that I don't freeze. Actually, you don't get to choose your response. People who have childhood trauma are much more likely to freeze. And for combat service members, this is often trained out of them, right? You can influence your emotional experiences and your triggers in the duration. So they are taught to perform in combat situations. But the fight, flight, freeze serve an evolutionary purpose. Flight, you get away from the lion. Freeze, or fight, if it's the last resort and you can't do anything else, maybe you fight the lion. The freeze response from an evolutionary perspective is helpful. A lot of prey, predators won't eat dead prey. So freezing makes you look dead. Additionally, it reduces blood loss if you're injured. So you're not flapping around, you're freezing, which reduces blood loss after a major injury. So there are adaptive qualities to this freeze. And someone put in the chat, I've heard people say fear is a primary initial emotion and then anger is experienced after that. Yes, since fear is less acceptable to express and does not allow us to control the situation, then anger takes over 100%. So our service members, fear, especially in PTSD, may be the initial reaction, but then it quickly turns to anger because that's powerful. The job for us therapists is to help them slow down, recognize what that initial signal is, and then respond to it rather than automatically turning angry and aggressive. Because sometimes you just need to sit with that fear Like a lot of our anxiety-based treatments and in PTSD, it's habituation of that very intense fear response. So what are your triggers? And I imagine I'll probably get less feedback in the chat for fear rather than anger because this is not as socially desirable. Things that make you have that fight, flight, freeze response. Hearing something unexpected in the house. Yes. Rattlesnakes. That's adaptive, Jenna. Large birds. Interesting. Unleashed dogs. Yes. Bees. Absolutely. Okay. Mice suddenly stopping in a car. Unknown snake, spider. Unknown. Okay. So I feel like Deborah has some street cred because she's not scared of all snakes and spiders, just the unknown ones. Anytime my boss calls, that's hilarious. You know why? Because that's the higher order, the rostral parts of your brain, the cognition that is interacting with those lower emotion systems and telling you your boss is scary. That's a really good example. Kids, dogs, running into the street, great needles. The IRS love it. Yes, don't take away your money. Really good examples. Perfect. Now, when I can't find my kid in the store, absolutely. Yeah. So what are the physical signs that you're becoming fearful? And this can be anxiety based, right? Anxiety is fear for a future event. Fear is immediate danger detection. Oh, you get a headache, so you get some tension in the headache. Absolutely. Other signs that you're having anxiety or fear. Chest tightness. That's my first one. I know that I'm anxious because I start getting a little bit of chest pain. Upset stomach. Yep, that's a common one. And what happens when we become anxious or fearful, we change the way we breathe. And so if you've done breath work before, you want it to come from your belly and then your chest holds kind of still. And I've done a good bit of breath work, but then I know when I'm anxious because I get these shallow breaths that are not as adaptive and it makes your chest muscles hurt. Hyper focus, trembles. Absolutely. So the hyper focus, your brain is trying to protect you. Absolutely. Really good. Having your patient recognize these symptoms, these signs, these physical signs in themselves is really important. Oh, I love it. Noises get louder. That's a great one, right? Because you become hyper focused and get hot. Having your patients recognize these physical signs, so important, especially if fear is a dirty word for them. And that way they can recognize it as a fear response or an anxiety response rather than something they have to be aggressive with. Joy, happiness. Okay. This promotes life. Resource acquisition. That's what we talked about, like in the major adaptive systems, the review of systems. Listen, joy doesn't get enough attention. Okay. People who have higher levels of positive affect, happiness, are more successful in relationships, in their jobs, in their education, with people. And it's not just that luckier people feel happier. The happiness comes before the good outcome because it does things like this. It opens your ability to think and be creative and problem solve. They've even done studies with doctors and lawyers. And anytime I do an in-person presentation, I bring snacks because snacks make people happy. If you don't like snacks, I feel like we couldn't be friends. Like snacks just make people happy and it increases your positive affect and it allows you to think and be more creative. And they gave they had a sample of doctors, they split half and they gave them lunch. All they had to do was feed them. And then the other half, they didn't give them anything. And they said, please diagnose these cases. The doctors who got lunch were more accurate in their diagnoses than the doctors that didn't. And so maybe it was a blood sugar thing, but I also think it was related to positive affect. Lawyers, same thing. You give them candy. Lawyers can afford candy. You buy it for them, you give it to them, and they make better arguments. We need joy in our life. You should definitely bring food to your PCM appointments. Oh, I feel like I would be a much better therapist if I just fed all of them. So it moves you toward the pleasant event or object, for example, food or friends. So what makes you guys happy? What are your triggers for happiness? Friday. Yes, Friday's a great trigger. Cute dogs, absolutely. All dogs, mountains, friends, warm weather, my son's laughter, good music, inspirational messages, children, sunny, warm days. Ah, being in the sun, look at you guys, being in nature, absolutely. So, oftentimes our patients have a lot of difficulty recognizing what their triggers for happiness are. So, you need to have them think back to when the last time it was. And you need to ask them what their body is doing. So people actually feel more relaxed when they are happy. The muscle tension goes down. Your heart rate can go up in excitement, but also it can go down if you're feeling relaxed. And I give the example of my husband always makes fun of me when I get together with my girlfriends. And if there's been at least a half a cocktail, he's like, the volume level just goes up if there are three or more of you. And it's true. And he's like, and none of you hold a linear conversation. It's skipping all over the place. But that's happiness. It's opening your ability to think. So you think of more random things, I'm kind of a loud person anyway. So it increases your energy, your heart rate because you're excited. And that is really a sign. I take it as a compliment when people become that way around me because I view it as genuine happiness. So have your patients identify the last time they were happy. Sadness. Okay. People don't like sadness. It hurts. But the evolutionary advantage of sadness is that it conserves energy after a loss. So when you become sad, the death of a loved one, you could panic. You could engage in frantic activity. That's not adaptive. That loved one is already dead. But becoming still, going into yourself, conserving that energy will allow you to rest and restore. For humans, it allows mental calibration of values. Funerals are painful, but I kind of like attending them because it really helps me focus on what I am doing and if I am living according to my values each time I attend it, because it's really like a shock to the system and it helps you consider what your behaviors are. In terms of your thinking, you reevaluate the things that you have left. So, being a psychologist, there's no lack of opportunity to do side jobs or extra work or this or that. And I remember going to the last funeral I went to, and I was like, well, I really need to decrease the amount of yeses I give for side gigs because my children are small and I want to see them. I mean, most days, some days they're terrorists and I wish I had a nanny. But it does make you consider like your own behaviors, makes you consider what is important. When you get sad, it actually reduces your movement to reserve energy. You feel like in really like organic depression, when people are slow, psychomotor, is it psychomotor retardation where they're so slow? Now I'm blanking on the name of the symptom, but people literally move slower. They cannot engage in the same level of energy and movement. And so, yes, like molasses. Thank you, Jenna. And so what are some physical signs that you all are becoming sad? Ah, no one's biting on this one. Increased sleep. Absolutely. Yep. Helps you conserve energy. Not long naps, no patience, crying. Yeah. Going to bed earlier, fatigue. Yeah. Everything feels hard. Good. Low energy, isolating. Absolutely. Perfect. Classic. Yeah. Avoidance. Lack of appetite and heaviness. Those are all great physical signs. So having your patients recognize these physical signs is really important because they may not know that they're sad. And then pointing out that these are very common reactions to feeling sad can be powerful for them. It can allow them to tap into the adaptive side of sadness. Disgust. Okay, did my dissertation on disgust because turns out I filled out a disgust measure in graduate school and I have very high levels of disgust. But Don't worry for me. I had 2 children. And so I have now habituated to icky things all over the place. And I often don't even blink for normal disgust triggers like feces and vomit and other things that are common with young children. So disgust is an adaptive emotion. It promotes hygiene and decreases illness. Think about it. For much of human history, we didn't have germ theory. We didn't know these invisible things could make us sick, but we were still disgusted by rotten food, by feces, by death, like decaying bodies. And all of those things, avoiding those things actually keep us healthy. That's a good thing. The effect on your cognition or your thinking, it makes you want to avoid it and it moves you away from the thing. I don't know if you've ever, if you went to an SEC school like I did in college, if you've been standing outside in a big group, maybe it was late at night and someone vomits on the sidewalk. If you weren't classy enough to have that experience, it's common at SEC schools and you can just see everyone back up. Like it's this group disgust of everyone goes back. Now, the military really does a nice job of having people habituate to discuss, much like parenthood. And medics, they go through training. So you're no longer disgusted by blood or burns or wounds that normal people would find disgusting. And so what's interesting about humans is that higher level cortex really influences our disgust triggers. And now we do this thing where we have moral disgust. We have disgust at people's amoral actions and normal core disgust, so feces and that kind of thing. But also we have now applied disgust to human behavior. So anyone brave enough to list some disgust triggers that weren't already mentioned? I hear things like people who abuse other people, blood and entrails. Yep, that's a pretty classic one. Bugs, rotting fish, rotting food. Perfect. Nose picking. Yep. My 3-year-old's really into that. That's fun for me. Roadkill. Absolutely. And loud chewing. Yeah. Cleaning a poo out of undies. Yep. Oh, there's a parent, I bet. Hearing about someone hurting someone else. It's a moral disgust trigger. Good. Yeah. And physical signs, your heart rate goes up. You get muscle tension. Your vision becomes very tunneled. And your stomach, like you feel disgust in your stomach. Great. Okay, again. Now, this is a feeling wheel. I know that every mental health provider has used a feeling wheel, but the first step to regulating an emotion is to identify it. And here are the 5 basic, but someone brought this up, or a couple of people brought up comments about this. There are 5 basic emotions, but they can blend with one another. Or you can feel sadness and then quickly suppress that with anger. Or you can, they can feed off each other and you can magnify 2 emotions. So you want to have the person have this handy because they may not yet have the language to identify and label their emotions. If feelings wheel is your most popular tool, absolutely 100%. And another thing, someone brought up the comment of do you consider rage part of the anger system? I do. And you can vary between irritability or irritable and rageful, but it's all in the brain part of this anger system. So help your patients identify, give them a visual. Okay, quick thing here. Identifying of facial expressions. There was a study in Portuguese college kids, and it was a large sample, about 1,200, I think, larger than that. And they asked them to identify different facial expressions because, again, combat veterans, much like I said in the video, combat veterans actually have a harder time identifying facial expressions because they overrate how many expressions are angry. And so that can produce the fear response in yourself or other emotional responses if you are not accurately reading people's emotions. And so, one, you need to know what you look like when you experience an emotion. And I recommend all of you look in the mirror and try to make your facial expressions. Although Zoom has really changed things. And now, unfortunately, I can watch myself on lots of different meetings. And I actually make sure if I am able to, I click off of my camera on a lot of presentations because I find that I kind of analyze my facial expressions a lot more when I actually have to see myself. But this study is interesting in that it found a couple things. They showed college kids pictures of facial expressions. So just the oval of the face, men and women making the same facial expressions. And who would you guess was more accurate in detecting facial expressions, men or women? Any toss up? All right. So I just had like 25 responses for women. Yes. But only for a couple emotions. Women were more accurate in rating anger and contempt, but not the other emotions. So contempt is kind of this blended emotion of a little bit of disgust and a little bit of anger. What was also interesting is that both sexes were able to recognize facial expressions made by women easier than men. Also interesting. So this is the study here if people are interested in pulling that. But it sets us up for this next game that we're going to play. So you all, as mental health providers who are emotionally intelligent and connected humans, can you name these emotional expressions? Please wait like 1 second, 2 seconds before you start typing in the chat. And don't look at other people's answers. Let's just see if you can pick up the emotion. Okay. What do you guys got? What emotion is this? Confusion, annoyed, anger, good. Disgust, okay. Irritated, puzzled, confused, good. Skepticism, sad, disgust, can't name it, confused, good. Okay. Excellent. Okay, so a variety here. And this is actually what we use for the anger expression. So the eyes are furrowed and the brow here, annoyed. So annoyed, irritable, any of those types of flavors would make sense here. The mouth is tight. That Portuguese study with the 1,200 students, anger, annoyed is accurate. Yeah, that in that flavor of anger, irritability and anger, annoyed. Anger was the least reliable emotion. So people had the most trouble identifying anger out of the 5 basic emotions. So yes, we're picking just from the 5 primary emotions. So this is the anger expression or an anger expression that we try to get to notice the eyes, the brows, and the tight lip. Okay, let's play the next one. 5 basic emotions. Subtle. What do you guys see here? Sadness, sad, 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 sad. Okay. Good. All right. So we get lots of bored. Yeah. Sad. Good. So the eyes kind of give emotions away for me. And this one, you see how heavy the eyes are? And the mouth is kind of more neutral. But if you see a baby who is sad, oh, and my little 3-year-old, I know he's not a baby, but he'll always be my baby. His sadness is so exaggerated. It's literally like an opposite of a smile. He's like, and adults don't do that as much, right? With sadness, it's a little bit more subtle. It's more in the eyes. But yes, this is what we show people with the heaviness of the eyes. The mouth is in a neutral position here, but can be downturned. Good job, guys. All right. All right. What do you got? Happy, joy, joy. Yep. Okay. Happiness in the Portuguese study was the most identifiable emotion. People can identify when people are happy. It's much easier than the other negative emotions. Okay. What do you got here? Disgust. Good. Yes. Yeah. Perfect. Okay. People got disgust. You see, disgust, its giveaway is the mouth because it evolved from your GI tract, right? To keep you from ingesting rotting foods and stuff that would make you sick. So literally people, when they're disgusted, the nose scrunches because usually of the foul smell, and the mouth And then even when people are really disgusted, you could see them retch a little bit. And this was the one, my 3-year-old, he didn't know what disgust meant, but he knew what yuck meant, because my cooking is so good that he's very familiar with the word yuck. But the mouth and the nose are really the giveaways with disgust. Okay. What do you got here? What do you think? What emotion? Fear, surprise, fear. Yep. Good. Okay. Perfect. Yeah. So surprise and fear both share the eye opening, right? Surprise is usually a little bit happier. So integrating what you see within the mouth. Fear is usually less smiley. So this is our fear picture that we use, and we get people to look at the eyes, the raised eyebrows, and the slightly open mouth. Fear was the one my 3-year-old couldn't identify or couldn't make. Okay. Good job, everybody. So now we can label the emotion. What do we do with it? I love the PTSD coach. The National Center for PTSD developed this app and has been updating it. And it's the app that I use when I do mindfulness or I need a visualization. This is the one I use. Here's the website. You can play with the website. I'll show you that in a minute. These are the muscle or the emotion regulation skills that are in the manual. And back in the day, there used to be things like adaptive emotion regulation and maladaptive or non-adaptive emotion regulation techniques. We now know that that's not the case. We all need a variety of emotion regulation tools. It would be perfect if we could all cognitively restructure our thoughts and every situation to be realistic and accurate and reduce our emotion. But sometimes situations are awful and difficult to experience, and we need just a little bit of mental distraction or grounding technique. And so we want our participants to use a variety of skills, not just cognitive restructuring. And you'll notice cognitive restructuring is not in here. We pilot tested it, cognitive restructuring, but because it's kind of this higher order metacognition skill, 3 sessions wasn't enough for people to get the skill. So we actually took it out of the manual, and they weren't using it. Patients weren't using it because we didn't have enough time to teach them how to do it. So this is really the list that patients rated as helpful, and they need a variety of skills. You can't have one. And I give the example of a few years ago, I had a melanoma, and I had to get it removed. I have so many great emotion regulation skills. I have this amazing PTSD coach app that I use. And I remember, so I was a little naive to the process, and I went in for those of you who are unaware, back in the day, they used to just cut the chunk of skin out, and then they would cauterize your wound to keep it from bleeding. So when she was, burning up, trying to stop the bleeding, I wasn't looking at it. I remember just feeling overwhelmed and kind of disgusted because you can smell it. And the only thing I could do to kind of keep my stuff together was I counted the dots on the ceiling tiles. Those medical tiles that are super pretty and they just have 1,000 dots on them. I literally had to count the dots to regulate myself because I was just overwhelmed. And so similarly, our patients will have experiences where cognitive restructuring is just not available. Give them some other skills and a variety of skills. Here is the website if y'all want to explore that. Okay. I have another video of the website. Now, listen, I was recording this as my child slept in the living room. So again, listening to myself on camera is pretty painful. But if I sound funny, it's because I was trying not to wake up my child as I recorded this. So let's do another stress test for Shannon. Oh, wait, go back. I want to just show you the website. You can play around with it later.
So what you see here is PTSD Coach online. And they have a variety of skills that you can choose from, that a patient can choose from, and deal with any emotion dysregulation they may be experiencing. While the MERA manual provides feedback on 7 skills, we don't really care which skills the patient is using as long as they're regulating their emotions. So I want people to encourage use of lots of different skills and trying of lots of different skills, even if it's not in the manual. And I'll demonstrate one, this one right here. You can watch a clip of the National Center for PTSD staff who developed this. They will talk about the skill.
You're coping with a stressful situation. One of the most helpful things you can do is picture a pleasant scene in your mind. The Relax Through Visualization tool allows you to choose between a couple of different pleasant scenes so that you can engage all of your senses and really become calmer and more relaxed.
And then when the patient is done with the brief rationale, if they choose to watch it, they will have them rate their emotional distress. From 0, no distress, you feel amazing, to 10, most distress you've ever imagined. And so you rate your level of distress, and then you choose your scene for visualization, and it will walk you through this beautiful visualization, let's say on the beach, for about 5 minutes.
First, remove distractions. Let others know not to bother you. Make yourself comfortable so that your thoughts are on the image and nothing else. Sit or lie down in a quiet, comfortable place. Then, mentally scan your body for tense muscles. If you find a muscle that's tense or clenched, relax it. During the imagery exercise, involve all of your senses in the image: sight, sound, smell, touch, and taste. Get completely focused. The more focused you are, the better. Close your eyes or lower your gaze. In your mind's eye, you see yourself descending down a long, narrow, wooden stairway toward a beautiful, inviting beach. Your bare feet feel the rough, weathered step, and with each step, you feel more and more tension gently melting away from your body. As you continue down the stairway, you notice the ocean is a deep shade of blue.
Okay. So I really like the app. Again, I use it myself. The manual suggests that you download it on your own phone. I show my patients, I ask them to download it on their phone, but I literally will play the skills that we're about to review from the app if it is available. And again, I've picked the 7 skills that the patients rated highest in our pilot studies, but we don't care what skills they're using as long as they're regulating. So just encourage them to download the app, explore the website, but to start practicing the skills. So here are the skills that we teach in the MERA manual. And what we do is we introduce an emotion and we get them all riled up because they talk about their triggers and what their body is doing. And then we immediately show them how to do a skill because we want them to be a little bit activated with whatever emotion they're experiencing so they can see that the skill is effective. So sometimes providers are like, I don't want to upset them, or it gets a little intense in session. You want them to be intense in session because if they can practice with you and find benefit, they will go home and practice the skills. And again, I'm a pirate. I took the PTSD coach app and I put it in here. These skills are not my skills. So I'm just like collecting all of the things that are wonderful for emotion regulation skills. But you guys will know these skills, I'm assuming. Progressive muscle relaxation. Those with aggression are often unaware of their bodies. They're not aware that they're carrying all this tension around, which makes them more likely to act out if they do become angry or dysregulated. So we want to teach them what it feels like by tensing and releasing different parts of their body. The most important thing here is to have the patient rate the emotional intensity before and after the skill and do the skill with them. Okay, so muscle relaxation, you can play it on the PTSD coach app. I literally play it and I do the skill with them so they do not feel embarrassed. The worst thing you can do as a provider is introduce the skill, theoretically, give them a handout, and don't do anything. That's not going to be effective for them to go home and try it. It has to be some experiential learning. If your app dies, oh, heaven forbid, your phone runs out of battery, here is a little script that you can follow. Grounding is the second one. Again, sometimes we just need to detach from emotional pain. You can have physical option, mental options, soothing options. Um, and it is a way to keep your mind active and alert, but not on the thing that is causing you the emotion. And so you can have physical things. A DBT does a nice job of this, of like holding your hand under cold water and noticing the sensation, or holding an ice cube that produces physical pain but won't injure your skin, and feeling what that feels like, digging your heels into the ground. I really like the mental options. And maybe it's because these are the ones that I use when I need to ground, but reading printed words backwards. So dinosaur, like each letter RUASONID, or the sobriety test of saying the alphabet backwards. I'm like unable to do that while sober. So it's a good grounding technique because it takes a lot of mental energy for me. Soothing options. So having coping statements, um, having a safe place that you mentally can just check out to. So a mountain cabins in the woods, the beach on a sunny day, your favorite inspirational quote, either on your phone or somewhere where you can look at it. So again, this is distraction. It used to get a bad rap, but we need it. Like people need to be able to ground and have a little bit of a break when they're so amped up that they aren't able to use kind of the more advanced skills. Additionally, for each of these, you're going to rate the emotional intensity, whichever emotion they're feeling. It doesn't have to be the one that you just covered, pre and post. And then you want them to make a goal. I will practice grounding for how many minutes, how many times per week when X happens. I can predict when I need grounding. It's usually in medical appointments because I get a little amped up. And so for me, I will practice grounding for at least 5 minutes, 5 times a week when I am at my medical appointment if the procedure is coming up, or while in traffic. So for me, traffic is a trigger. So that's a good time to ground as well. Ooh, I like that. So someone suggested find 5 things in the room and spell them backwards. That's really good. It's like a higher level, like that's multi-step. Good for you. Okay, value-driven behavior. Values guide our behavior. I want you to think about your top 3 values. So jot them down. And then if anybody wants to write a value in the chat, I want you to think about how you can symbolize those 3 values in your life. Is it a picture? Is it a quote? Like what could remind you of your values? Because when we are constantly reminded of the people we want to be, of the things that are important, it kind of gets this cognitive like interference with when we want to react emotionally. And so for me, my background is like a rotating picture of my 2 kids, and that helps kind of ground me to my values. I had a veteran who really struggled. He smoked a lot of marijuana, and his girlfriend got pregnant. This was his first child. And he said, I want to be a good father. Like, that is my value. I want to be a good father. And so, what he did is he put a picture of his ultrasound on his box he used to keep his stash in. So, anytime he wanted to smoke, anytime he got triggered, he had that picture on the box. Or had a veteran who would have a lot of road rage. And so he put on his visor, and in Tampa, there is no lack of traffic in Tampa. He put a picture of his family on his visor so he could flip it down and quickly look at them instead of engaging in road rage. So picture of me being able to hide gratitude. Absolutely. One thing to note that people with PTSD sometimes think because other people are gone, so battle buddies have died, or people were suffering, that they don't deserve to be happy and to live according to their values. So sometimes cognitions about like, am I like worthy of doing this come up? And then you can have a nice discussion about living according to our values is often honoring to those who have passed. Okay, diaphragmatic breathing. The best way to decrease your sympathetic activation, that fight, flight, freeze response, that anger response, is your breath, because your breath kicks in the parasympathetic response. The military really uses breathing very effectively. And so this is on the app as well. I open it up. I ask them to rate their emotional intensity, pre and post skill. And then I do this exercise with them. So again, it needs to be experiential. They need to do it in session. Now, sometimes people talk about how breath work can trigger anxiety. Have you guys had that as providers? I don't find a lot of people getting super anxious with diaphragmatic breathing. I think if people have panic disorder, it's more common, right? Because they are very in tune to their physiological sensations. But I don't find it a lot in my current PTSD samples. So that's one of the caveats. Like if you become anxious, like, you can step out of this exercise. I don't find that to be too much of a problem. Have the person rate the goal for how frequent they will do it, for how many minutes, and so on. Okay, mindfulness. Emotions can be scary. So facing one's emotions in a non-judgmental way is so powerful. And again, this was the fear of being able to handle one's emotion was the top concern for people dropping out, of why people dropped out of PTSD treatment. And so what we want to do is we want to help people experience their emotions in a non-judgmental way, not trying to control them, but really just being aware and letting them wash in and wash out, and practicing it in session. And so this is not in the PTSD coach app, I don't think, but what we have them do is rate their emotions, their experience right in session. Maybe for you right now, it's I am tired and bored. This is almost hour 3. We only have 17 minutes left. What it feels like in your body. So maybe you're feeling sluggish. Maybe you're feeling a little lethargic. Your thinking is slow. What triggered it? I've been sitting listening to this lady for 3 hours. What's the purpose of the emotion? So it's a little bit easier with the 5 basic emotions, right? Boredom is a little bit harder. Like maybe it shows you that you need to change your situation or you're not being fulfilled, but have them write the purpose. And for the 5 basic ones, agenda protection for anger, danger detection for fear, life promotion for joy and happiness, keeping you from getting sick for disgust, and then I don't know what was the 5th one. Anger, sadness, fear, disgust, happiness. Yes, all of those. So what's the purpose of the emotion and how long it lasted? Because here's the surprising thing. Oftentimes, if you will just sit with your emotion, it won't last that long and you're strong enough to withhold it. As I was developing this talk, it made me like reminisce a lot about grad school. And my mentor passed away a few years ago, and I had this sadness coming up. And as I was going over this, because this is his mentorship was really the point in my career where I turned to emotion regulation and aggression work. Like I just noticed what it felt to be sad and tried not to hide from it, which is easy to do if you're a busy person. So just sitting with it. Okay. I keep talking about joy and happiness. Positive affect precedes better outcomes in life. Even if someone has PTSD, if we can increase their positive affect, it will help them reduce their negative emotions. So your brain is hardwired for negative and positive emotions. If you increase these positive emotions, you can cope with the negative ones. Additionally, I talked about how positive affect can help you problem solve a situation. It can make you feel better. So do things that you once enjoyed. If they're not currently feeling happy, give them some examples of things that either commonly produce happiness or that produce happiness for them in the past. So go outside for a walk, drink some coffee, practice religion, watch YouTube videos of dancing cats, whatever it is. Also, working out. This is a military sample. Any amount of physical exercise is really good. Working out 5 days a week is as effective for reducing depression, mild to moderate depression as an antidepressant, working out, get people moving. This is a really important one for people to focus on. And again, you want them to write the goal for every one of them. Positive imagery. This was I showed you, I think it was like the beach scene of the little video on the PTSD coach app. This is really the goal of this is to increase relaxation. If we can bring our general level of arousal down just a little bit, when we are dysregulated, it's going to take more stimuli to get us to behave aggressively. So this is really like putting money and energy away in the bank, trying to relax and prior to something happening. Now, you can do this while you are activated as well, but I always like to do this to kind of bring down your general level. It allows you to focus your mind. It allows you to think about a safe, relaxing space. You can do this with the PTSD coach, or if you don't have as much ADHD as I do, you could do it just in your own brain, and you can self-lead it. I'm not able to do that and stay focused. But some people can look at one image and kind of guide themselves, but it takes practice. Okay. If you want to change any behavior, you have to track it. So I already talked about the OAS, but if you want to increase any behavior, weight loss, exercise, better sleep, less aggression, you got to track it. And so if you want someone to practice skills, you have to ask them to track it. And we try to develop the sheet to make it easy. What day, what triggered the emotion, and they could just simply put an X in one of these boxes for how many minutes they practiced this skill and was it effective? Yes, partially, no. You want them to see when things are effective and when they are not, which skills help in which situations. And you want them to try a variety of skills. So having them bring this to session and you looking over it as a therapist will give you a good idea of how it's going and like what is effective, what needs to be tweaked. If skills aren't working, they may just not like it, or they may not be doing it effectively. So you can help them problem solve. Okay. So I'm supposed to finish at 11:50. So questions can be asked or comments. So here is a summary. Emotions are adaptive and they promote survival. I hope everyone goes back and watches the YouTube clip from like slide 2 about the major adaptive systems for psychology. We need to understand how these systems work in order to really have an empathetic and accurate understanding of when things do go off the tracks. And so aggression can be one of these problems and especially for veterans and service members with PTSD, with TBI. Those are my populations. And we are to expect this because not only are they symptoms listed in the DSM checklist, but also we know when our agenda is thwarted, we are more likely to have aggressive behavior. Existing treatments for aggression are moderately effective at best at reducing aggression. Now, again, because there are so many correlates to anger and aggression, if you can take a whole health perspective, absolutely try to do that. But I'm suggesting another novel treatment method. It's actually not that novel. Again, I just pirated most of it. That includes building emotion regulation skills. So helping people recognize the adaptive value of emotions that we have in all mammals, in a lot of vertebrates, across all humans, young and old, helping them recognize why they're there, the purpose that they're trying to serve. And then also skills that are effective at reducing dysregulated emotions. And so MERA is one of them. The patient manuals has all of these handouts. And there's a couple, that's all I have. There are a couple questions that I'll kind of sift through here. So handout, we have them fill out the OAS at every session. So we want them tracking it. And that is in the treatment manuals. Oh, Jenna already answered that. See, she's on top of it. The presentation will be shared. Jenna, I'll let you fill these.
Yeah, so I we need to talk to Shannon about whether or not we're going to be able to post the actual recording, but obviously the handouts are available, the manuals are available, the slide handouts are available, and I know that Shannon is such a proponent of people taking this. I mean, why do you create something if it's not going to be used? So if you can't find something or you're struggling, reach out to us, reach out. Her email's right there. I'm going to put her cell phone in the chat. Just kidding. And again, one of the things I have appreciated about Dr. Miles across the years is her commitment to making this available and wanting providers to use it, wanting to hear about experiences and things like that. So hopefully this is the beginning of a beautiful relationship, and you can feel free to reach out for sure. We also, I mean, there's a couple other resources. We had another recorded webinar that is on our website that Dr. Miles did a few years ago. She's been a guest on our podcast. We just can't get enough of her. So I can try and find some of those links to put in the chat. I had a question. I wasn't seeing any big questions that we didn't hit. You did a fabulous job of kind of hitting them along the way. But one of the things I'm thinking about is while a lot of our providers obviously come to our presentations because they are interested in working with military connected clients, I imagine that this isn't just, relevant for military connected clients, and it's, appropriate to be using with civilians. And are there other populations that you have kind of thought of or people have reached out to research this? Like I'm thinking about kind of athletes that, there's sort of a required amount of aggression and kind of how that plays out. So just wondered if there's been any crossover with other populations and groups.
Yeah, great question. So I'm funded to study veterans and service members. So like these treatments were developed specifically for service members and veterans. All the examples are service member related. But no, like we know that emotion dysregulation is related to aggression because we've looked at it in college students. We've looked at it in domestic violence, non-combat situations. And so it's really this transdiagnostic ability to interact with your emotions. And so when you talked about using the manuals, absolutely, I'd be happy to send you a Word doc if you have a different population and you want to change the examples for your trainees, because it's not just our service members; it's dysregulation, and currently we're looking at my academic affiliate is University of South Florida, and we're looking at pregnant moms who are abusing substances as the next group to treat because there tends to be a lot of aggression and dysregulation, and targeting pregnant moms while they're pregnant, they have this motivation. It's not about them anymore, and they're actually really amenable to treatment. So we're looking at that at USF, and then we're also incorporating an alcohol piece. Juliana Flanagan at Universus Services. Nope, sorry, I'm tired. Charleston VA at MUSC. We're working together to do a motivational interviewing for the alcohol component and then this MERA, because we know alcohol use is such a strong predictor of aggressive behavior. Can we incorporate some of those skills to help them use less alcohol and regulate their emotions?
That's great. I'm going to turn it over to Jeremy in just 1 second. Don said justice involved. I'm not sure how to interpret that one, but I'm like, do you mean mandated, or maybe you can clarify? But again, I don't know if you have thoughts about,
justice involved populations.
Perhaps that's what she meant.
Yeah, we haven't currently. Not yet. Just the opportunity hasn't arisen yet.
All right. Well, I hope you are seeing all the kudos in the chat. And I will turn it over to Jeremy so he can cover CEs and then we will close out. So kicking it to you, Mr. Karp.
Thank you, Jenna, and thank you, Dr. Miles, for an amazing presentation. The next step for meeting your CE requirements will be logging back into your CE21 account using this following link I put into chat here. Once you're inside your account, you should see a list of seminars that you've registered for or have attended. In the row for this particular webinar, there'll be a gold certificate button. What you want to do is click that gold certificate button, and then a smaller window will appear that displays the specific requirements for this training. Note that attendance cannot be taken before this webinar is closed. So when you click that gold button, the first thing you'll see is seminar completion. That's our attendance tracking. If it's not green immediately, give it a little bit of time for the data to be moved over from Zoom to CE21. If by Monday it's still showing it as red and that your attendance is not complete, go ahead and reach out to me and I can fix the issue. I'll put my email into chat. After attendance, the next requirement is to complete our seminar evaluation, which will be located right below that seminar completion tab. That evaluation should take roughly 10 minutes to complete, but please do note that you have 30 days to complete that survey. After your attendance requirement has been met and you've completed the evaluation, you will then be able to download your certificate. We would also like to emphasize that included in your registration for this training was a ticket for our upcoming presentation day of the conference tomorrow from 9 a.m. to 5:40 p.m. Eastern. We highly, highly encourage you to attend as we have an amazing list of speakers, topics, and presentations lined up. If you have any other questions regarding the conference, feel free to reach out to me and I'm happy to answer any questions. That's it for me. Thank you, everyone.
Fabulous. And I do want to take a second to quickly say, too, none of this would happen without Jeremy. You may have seen all the emails. He does so much work behind the scenes. So just a round of applause. It'll, silent one for Jeremy and all his hard work. It is a labor of love, I know, but we have made it more and more complicated throughout time, and Jeremy has taken it on with energy and grace and patience. So now, Dr. Miles, thank you. You made my dream come true. We talked about this for years. I love seeing things like I can use this today because that is our intention. We want to help providers integrate things into their practice. As soon as possible. And I think this is such an applied, fantastic, relevant, thing to have in your clinical pocket. So thank you for your hard work, your dedication to this part of the field, and for being so cool and coming back again and again to help us out at CDP. So thank you so, so much.
Oh, it's my honor. Really appreciate the opportunity. You guys are doing amazing work. So thank you.
And we really do hope to see you all. Tomorrow's a big day. We have one more half day this afternoon. Some of you may be joining us. And if not, we will look forward to kicking off tomorrow morning. And it's going to be a really fabulous day of talking about innovation and changes in the field and what do we do. And it's going to be fantastic. So see you tomorrow. See you this afternoon. And Dr. Miles, go put your feet up and rest. Thank you.